Good morning. Hello, everyone. My name is Amanda Hardy. I'm a fourth-year Med-Peds resident right here in Memphis at the University of Tennessee. I want to first thank SMA for hosting this event. It was really convenient for me, so I really like that. But thank you for the event and the opportunity to present this case. My case is called Collision Course, an unusual presentation of fatal mucormycosis following a motor vehicle accident. And so the first thing that I'm going to do, I'm going to kind of take everyone through the case, and then I'm going to show pictures from the case and conclude it with just a few discussion points about the diagnosis itself, and also just some key takeaway points. And so just to go ahead and get started with our case. So we had a 43-year-old female with a history of type 1 diabetes that was poorly controlled. She had an A1C of about 9. And a history of ESRD and a failed renal kidney transplant, who was, she was driving on a rural country road, and a truck going the opposite direction crossed over into the median. And when it did that, it hit the tail of her car, causing her sedan to spin, roll over, and fall into a muddy embankment. She sustained multiple injuries from that accident. It was a pretty significant accident, and I'll show you pictures of that. But it included C1 fracture. She had multiple rib fractures, multiple lacerations, as you can imagine, and she also had a fracture of her right humerus. She underwent fixation of that fracture of her arm, and then about a week later, there was noted to be signs of potential infection at that site. And so that was managed medically, and she was thought to kind of clinically improve enough to be able to be discharged 27 days after that initial accident and after her admission. And so she would be roughly about a week after she was discharged from that hospitalization. She presented again with concerns for infection once more. And you were starting to see kind of wound dehiscence and some purulent drainage from that site. At that point, she would be admitted. She would be started on antibiotics, thinking common things being common, this is likely a bacterial infection. And after being started on those antibiotics, she would also undergo debridement and irrigation with our surgical team of that infection. The initial cultures would grow rare mold. And so while awaiting final identification, she was started on amphotericin B. And it was after she would undergo another irrigation. And at that point, we would have final identification that this was, in fact, mucor. And so that would be a pretty difficult hospitalization for her. She would undergo a total of 7 debridement and irrigation procedures. And throughout that course, it was, each time they would show, have that dark, devitalized tissue that would be revealed. Ultimately, she would need to undergo exchange of her hardware. And she would, even despite that kind of rocky course, she would improve enough once again to be discharged, but not before she actually had to undergo following the hardware, she had amputation of that right arm, and then she would be discharged when she was able to kind of improve clinically. Unfortunately, it would just be a few days later that she would be readmitted. So this would be her 3rd admission at this point. And she would just have continued uncontrolled infection. CT scan would actually show that she had extension into the stump bed of that infection. And it was at that point that the medical team, and we had been very transparent with the family at that point, and kept them aware of kind of our clinical decision-making and what was going on in our assessment. And we were very honest with them, and we made them aware that this was an infection that was immediately life-limiting. And it was at that, we had palliative care involved, we had multiple teams involved, and the patient herself actually made the decision to go ahead and be discharged home to be surrounded by family. And it was just about 4 days after she was discharged home that she would succumb to that infection of disseminated mucormycosis, which was devastating. So that's kind of the general course there. And so now what I'll do is I'll go ahead and kind of show you pictures from this. And so we're going to kind of divide it into panels here. So the left, I'm getting my lefts and rights down this morning. The far left, you'll see those two pictures actually show from the scene itself. You see that very large truck there. And then importantly, though, the picture below that shows her vehicle clearly flipped, clearly kind of in that, like rolled over and in that kind of embankment. And then the picture in the middle shows a picture of the patient just shortly after that first admission. You can clearly see that she has multiple abrasions and injuries there. And I really think it speaks to just kind of significant that accident was. And then that last kind of panel actually shows during her third admission following amputation, you can see kind of her stump bed there. And you see the dehiscence, you see the necrotic tissue, and clearly not a controlled infection there. And so lastly, I kind of want to end on some points regarding the diagnosis itself and just some key points about the case. So Mucor itself is a rare, but it's a obviously very dangerous invasive infection. It's caused by an invasive opportunistic environmental mold. We mostly see it kind of in immunocompromised hosts, but there's also other patient risk factors, including type diabetes. And so our patient had type 1 diabetes, which certainly increased her risk. And even with early treatment, it can still be rapidly fatal. There's a source that estimates about 54%, but that takes into account all the different forms of Mucor. And just some points about this particular case. So she had rhizopus, which is one of the organisms that's thought to, cause mucormycosis. And there's different manifestations. We generally think of like rhinocerebral. I think that's the one we get tested on in medical school the most. We can all kind of think of that picture in our, step 1 books of that infection. But her infection was cutaneous in nature, at least initially, before it became disseminated. But when her vehicle flipped, she became inoculated at the time of that initial accident. She was thought to have a bacterial infection, common things being common, and that's how she was treated. But, it was the soil that was harboring that fungi. When it had gotten into one of her cuts or one of her wounds during that time. And importantly, again, the patient has certain factors like her history of type 1 diabetes, that should have made this a diagnosis that we would have considered early on. Granted, hindsight is 2020, but she fits kind of the picture here, and especially when we start to see kind of the dark devitalized tissue, something for us to consider. But that delay that took place, that actually gave the infection more time to spread, which is unfortunate. It wasn't until post-op day 27 from the initial repair of her arm that there was a debridement and irrigation, where that is something that potentially we could have done earlier on. So something we can learn from this case. But I guess one of the more striking points is that even considering this, it's difficult to say whether this would have made a difference in terms of the ultimate outcome, just because this is such a fatal infection. We would like to think that it would have increased her chances had we acted maybe a little bit sooner and had this on our minds. But I think this case really highlights kind of the significant mortality associated with mucormycosis, no matter how it may manifest initially, because while this was initially cutaneous, obviously it became disseminated later on. And so that kind of leads me with like these 3 take-home points, I think, from this case. And the first being that there's a need for increased awareness about this. And it's important for us to kind of like consider these especially fatal infections in in the right patients. She kind of fit certain patient factors. And so we all need to kind of just be clinically aware that this is a possibility, even if it's like, oh, yeah, you might see it one time, but that one time you see it is when it matters. Secondly, so this was a uncommon manifestation of a uncommon infection, right? And so even still, again, having that awareness, remaining vigilant, especially knowing how high the mortality is really important, especially in these high-risk populations. And then lastly, and I think this is a point about the art of medicine, is how important it is for us to watch our patients. I know that kind of sounds silly, but constantly reassessing, she would undergo so many different debridement and irrigation procedures. Once we were starting to see that was not going the way that kind of we had expected, maybe we could have had some of those conversations earlier. Maybe, there's a lot that we can look back on and say, this is how we would change our management at this point. But overall, still something to learn. And I appreciate y'all's attention and time. And thank you for the opportunity. Yes, so during the first debridement and irrigation procedure, there wound cultures were taken, and that's when we got the rare mold that was in that initial culture, and that's what's prompted us starting amphotericin B and isavuconazole at that time. And then it was that final identification which confirmed that it was in fact Mucor. I wouldn't necessarily say early on, because that first debridement and irrigation didn't take place until 27 days after her first, like when she first came in. And so, and there's a lot of data which suggests that kind of earlier treatment gives you obviously better chances of survival. But at that point, that infection had kind of been brewing for a while, 27 days if she was inoculated at the time of the actual accident. Yeah, I certainly, now certainly that would be something that I would have hoped to have happen. I don't want to, too closely critique my surgical colleagues, but I certainly think that would have helped guide us. But when we weren't, I think the initial thought was that this is a injury, you repair it, she gets better, she'll go home, that kind of thing. And it wasn't until she started having some complications and kind of having these signs of infection that it was like, oh, maybe we should have done that much earlier on. But having that information early on, yes, certainly I think would have helped the patient's case. So it actually wasn't an open fracture, but she did have so many wounds from her actual injury, including on that arm, that's where it's the speculation, but we feel pretty confidently that that's where she would become inoculated. Not necessarily obviously kind of in that site because it wasn't open, but she did have areas for that kind of hematogenous spread. Yes. And we feel pretty confident about that, just because, like you said, it is something that is found in soil, and she wasn't having these it's so related to kind of her injury and everything. Like, we have to ask ourselves, would we see this presentation if she didn't have this accident? And, I am confident in saying, no, we wouldn't have seen this. So it fits the picture quite well there. Right.
it's still taking so much time back.
Yeah, so the culture came back. It didn't take 27 days for the culture to come back. It took us 27 days for us to take her for that first debridement and irrigation. And at that point, I really have to give a lot of credit to Regional 1 here in Memphis, a little Memphis plug there, because we work really, really closely with the lab, and they're helping us and keeping us kind of really updated on those cultures. We actually don't find that it takes a month for us to get those final identifications. And we got those preliminary results of the rare mold pretty early on, because obviously this is a patient that we were really concerned about. So, and the lab was aware of that as well. All right, thank you all.